So this video is on normal anatomic landmarks in intraoral radiographs. The radiographic recognition of disease requires a sound knowledge of radiographic appearance of the normal structure. Intelligent diagnosis mandates an appreciation of wide range of variation in the appearance of normal anatomical structures. Similarly, most patients demonstrate many of the normal radiographic landmarks, but it is rare patient shows them all. Accordingly, the absence of one or even several such landmarks in any individual should not necessarily be considered abnormal. The radiographic appearance of various structures which can be visualized in IUPA can be classified as teeth, supporting structures, maxilla, mandible, and other restorative materials. So it can also be classified as radio-opaque and radiolucent landmarks. So under radio-opaque landmark, we have separately, we can enumerate for maxilla and mandible. So for maxilla, it includes enamel, dentin, cementum, lamina dura, alveolar crest, cancellous bone. So that is common for both the maxilla and the mandible. And pertaining to the maxilla, it also includes nasal septum, anterior nasal spine, floor of the nasal cavity, maxillary sinus, inferior nasal concha, and nasolabial fold. Coming to the mandibular radiopaque landmarks, as I already said, there are some common landmarks. Along with that, genial tubercle, ridges, and inferior part of the mandible. Now coming to the radiolucent landmarks, here again it is classified as maxillary landmarks and mandibular landmarks. There are some common landmarks which is for both the maxilla and mandible, which includes pulp, periodontal space, nutrient canals, and pertaining only to the maxilla is the structures like intermaxillary sutures, incisor foramen, incisor fossa, nasolacrimal canal, maxillary sinus, and then nose. Pertaining to mandible, it is lingual foramen, symphysis, mental fossa, mental foramen, mandibular canal, and submandibular fossa. So starting with the structures individually, first is tooth. The tooth shows all the structures like enamel, dentin, cementum, pulp cavity, and root canal. I think you should be pretty well knowing about all these things. So this is the enamel, then you have the dentin, then you have cementum in the roots, then you have the pulp cavity and the root canal. Next is cervical burnout. So what is cervical burnout? Radiographs sometimes show diffuse radiolucent areas with ill-defined borders present on the mesial and the distal aspect of the teeth. So like in here and here, and in the mandible and the premolar, the distal aspect. So distal aspect of the premolar. So these regions appear in between the edges of the enamel cap and the crest of the alveolar ridge, and it should not be confused with the root caries. So it is an artifact and it is due to the less X-ray absorption in this area. Now coming to the supporting structures. First one is lamina dura. So lamina dura is nothing but it's a thin radio-opaque layer of dense bone surrounding the tooth socket. So it is thicker than the surrounding trabecular bone. So this is the lamina dura. So this appears more radiopaque than the surrounding trabecular bone. And the thickness will increase with increase in the amount of occlusal stress. So a tooth which has more occlusal stress will have a prominent lamina dura. Next about the alveolar crest. So the gingival margin of the alveolar process that extends between the teeth is apparent on the radiograph as the radio-opaque line called as alveolar crest. So it is considered as normal if it is not more than 1.5 millimeter from cemento-enamel junction of the adjacent teeth. The sharp angle with lamina dura, which is more, so is suggestive of periodontal pathosis and also seen in aging. Next is periodontal space. So periodontal ligament space is primarily composed of the collagen. So we could see that radiolucent line. So that is the periodontal space. So this appears radiolucent between the tooth and the lamina dura. So this thick radiopaque line is the lamina dura and this is the tooth. In between that we could see the radiolucent line. So that is the periodontal space and it is generally thin in middle third of the root and wider in the crustal region and also wider in the root apex area. So it is also function related. So next about the cancellous bone. So this lies between the cortical plates in both the jaws and it is composed of thin radio-opaque plates or lines and rods surrounding many small radiolucent marrow spaces. So can you see the marrow spaces here? So you have a thin radiopaque line surrounding that. So this cancellous bone is commonly seen in the anterior region which appears thin and dense trabeculae and it is also seen in the posterior aspect and it gives a thicker and numerous spaces in the posterior jaw. So next about the maxillary landmark. Maxillary landmarks. The first is incisive foramen. So it is also called as nasopalatine or anterior palatine foramen. So the opening is located in the midline of the anterior portion of hard palate, directly posterior to the central incisor. On the radiograph, small ovoid or round radiolucent area is located between the roots of the maxillary central incisor. So this particular landmark you can see in the maxillary central incisor projection. So next is nasopalatine canal, which is also called the superior foramina of incisive canal. So there are two small openings of the canals here. So this is the superior foramina of incisive canal. And these two small canals extend downward and medially from the floor of the nasal cavity and join together to form the incisive canal and share a common exit, that is the incisive foramen. Two small radiolucencies located superior to the apices of the maxillary central incisor. So we can see at the apex of the maxillary central incisor, two small round radiolucencies, and it is also in the floor of the nasal cavity and near its anterior border on the both side of this septum. So next is the median palatine suture. So it is also called as intermaxillary suture. So this is a thin radiolucent line which is seen in between the maxillary central incisor. So this is bonded on both the side by dense cortical bone that appears radiopaque. So can you see a thin radiolucent line here? On either side of it you have an opaque line that is due to the cortical bone. The suture may terminate at the alveolar crest in the small rounded or V-shaped enlargement, and this suture fuses with age, so it may appear less distinctly in the radiograph. So next is the lateral fossa, which is also known as incisive fossa or canine fossa. So this generally appears as a radiolucent area between the canine and the lateral incisor. Generally you will see this landmark when you take a canine projection. Next is the nasal fossa, otherwise called as nasal cavity. It is a large radiolucent area which is above the central incisor. So these are the maxillary incisors, and above that you have a large radiolucent area. This is nothing but your nasal fossa. So next is nasal septum. So it is a vertical radiopaque partition that divides the nasal cavity. So this is a nasal cavity and this is the septum. So nasal septum may be superimposed over the mid-palatine suture. So this is the mid-palatine suture and this nasal septum superimposes the mid-palatine suture. Next is floor of the nasal cavity. So a dense radiopaque band above the maxillary central incisor. This is the floor of the nasal cavity. Next is the anterior nasal spine. So this anterior nasal spine is V-shaped. So can you see this V-shaped radiopaque area which is located at the intersection of the floor of the nasal cavity and the nasal septum. So this is the floor of the nasal cavity on either side, and this is the nasal septum, and this is the V-shaped radiopaque area, and this is the anterior nasal spine. Next, the inferior nasal concha. So generally in the nasal cavity, we could see a diffuse radiopaque area on either side of the nasal septum. And this diffuse radiopaque mass or projection within the nasal cavity is your inferior nasal concha. Generally, we will see this landmark in the incisor projection. Nasolacrimal canal. It is a well-defined, slightly ovoid radiolucency just above the apex of the maxillary canine, and it can be seen when there is a steep vertical angulation is given, and it is seen more routinely in a maxillary occlusal projection. So this image is a lateral maxillary occlusal projection, and which shows all the maxillary teeth, that is the central, lateral, canine, premolar and the molar. This is the apex of the canine, and there is a ovoid radiolucency which is your nasolacrimal canal. Next is nose. It is a soft tissue of the nose, is frequently seen in the projection of the maxillary central incisor, lateral incisor, which is superimposed on the roots of the teeth. So this is the shadow of the nose. The image of the nose has a uniform, slightly opaque appearance with a sharp border. Sometimes the radiolucent nares may be identified. So generally we will see only this shadow. Sometimes you can see the radiolucent nares which is superimposed with the roots of the maxillary central incisor. Nasolabial fold. So this is an oblique line demarcating a region that appears to be covered by slightly radio opacity frequently seen in the premolar region. So this is the premolar, and this is an oblique line which reflects a nasolabial fold. So the line of contrast is sharp. Like in for your nose, the borders are sharp, and the area of increased radio opacity is posterior to the line. So the image of fold becomes more prominent with age. Next is maxillary sinus. It is a radiolucent area located above the apices of the maxillary molars, and the borders of the maxillary sinus are composed of dense cortical bone and appears as radiopaque line. So this is the floor of the maxillary sinus, and we could see the septas here. Septas are within the maxillary sinus, which are radiopaque line within the sinus. So these are the septas, and we could see nutrient canals within the maxillary sinus. What are these nutrient canals? They are nothing but a narrow radiolucent band which is bounded by two thin radiopaque lines. So next is Y line of Ennis. So it is inverted Y. So this refers to the intersection of the maxillary sinus and the nasal cavity. So a radiopaque upside down Y-shaped line. So this is that Y-shaped line. So this is that Y-shaped line which is formed by the intersection of, this is the floor of the nasal fossa, and this line is the anterior border of the maxillary sinus. So which is located usually above the maxillary canine. So this inverted Y line of Ennis we can see in a maxillary canine projection. Next is maxillary tuberosity. So it is a radiopaque bulk structure which is seen posterior to the maxillary third molar region. So this is the maxillary tuberosity. So this you generally see in a maxillary molar projection. Next, coming to the pterygoid plates. So what are pterygoid plates? A single radiopaque homogeneous shadow without any evidence of trabeculation. So these are the pterygoid plates, and it may not be seen in all the radiograph. Maybe for a maxillary third molar projection where you have kept your IUPA very behind, so it may cover the pterygoid plates as well. So in such radiographs, you can see the image of the pterygoid plates. So this purple arrow is your pterygoid plate, and this black arrow which is indicating the hamila process. So next is the hamila process. Hamila process is a radio-opaque hook-like projection posterior to the maxillary tuberosity. So this is the maxillary tuberosity and this is the hamila process. The length, shape and density is variable for different individuals. So this hamila process would be seen in a maxillary third molar projection, and when we sometimes keep the radiograph very posteriorly while exposing, it may cover the pterygoid plates as well as the hamila process. Next is zygoma and zygomatic process. So it is a diffuse radio-opaque band extending posteriorly from the zygomatic process of the maxilla. J or U-shaped radio opacity which is located superior to the maxillary first molar. So when you make a maxillary first molar projection, you tend to see this image, this U-shaped radio opaque image above the maxillary first molar, which is nothing but your zygomatic process on the zygoma. Now coming to the mandibular landmarks. So far we were seeing the maxillary landmarks. We had spoken about both the radiolucent and the radio-opaque landmarks. Now let us see about the mandibular landmarks one by one. So next is the genial tubercle. So genial tubercle is a ring-shaped radio opacity which is below the apices of the mandibular incisor. So when you make a mandibular incisor projection, we tend to see this genial tubercle. Next is lingual foramen. So lingual foramen, it is a small radiolucent dot which is inferior to the apices of the mandibular incisor. So this is the lingual foramen we can see in the mandibular incisor projection. Next is nutrient canal. So the vertical radiolucent lines are evident in the mandibular, central incisor, lateral incisor projection, and they are more prominent in the anterior region and as well as in the edentulous mandible. Next is mental ridge. So this is the mental ridge. It is a thick radio-opaque band that extends from the premolar, mandibular premolar to the incisor region on either side. So it may appear superimposed on the mandibular anterior teeth. Sometimes, so this is actually seen in the periapical region of the mandibular incisors. Sometimes it might be seen superimposing with the mandibular anterior teeth. Next is the mental fossa. So mental fossa is a radiolucent landmark which is above the mental ridge. So the appearance varies and is determined by the thickness of the bone in the anterior region. Next is mental foramen. So it is a small ovoid or round radiolucent area located in the apical region of the premolars, mandibular premolars. So it is frequently misdiagnosed as a periapical lesion because of its apical location in relation with the premolar. Next, coming to the symphysis. So this image is a mandibular symphysis in a newborn infant where it is not fused yet, and this is the symphysis fracture which is evident in a mandibular anterior projection. So this radiolucent line is the fracture. So symphysis is a radiolucent line through the midline of the jaw. Next is mylohyoid ridge. So this is a mylohyoid ridge, and this is the external oblique ridge of the mandible. So it is a dense radiopaque band that extends downwards and forward from the molar region. So this is the mylohyoid ridge. So it appears usually more prominent in the molar region and may be superimposed over the roots of the mandibular teeth, and it may appear continuous with the internal oblique ridge. So it might extend from the internal oblique ridge from the molar to the anterior region. Next is internal oblique ridge. So a radiopaque band that extends downward and forward from the ramus. Depending on the technique used, the internal and external oblique ridge may appear superimposed on one another. So when the ridges appear separate, then the superior radiopaque band is the external oblique ridge and inferior radiopaque band is the internal oblique ridge. So this is the external oblique ridge and this is the internal oblique ridge. Next is external oblique ridge. It is a radiopaque band which is extending downward and forward from the anterior border of the ramus mandible. So this is anterior border of ramus mandible and it is extending downward and forward and it typically ends in the mandibular third molar region. So it is ending over here in the mandibular third molar region. Next about the mandibular canal. So it is actually a radiolucent band which will be outlined by two thin radiopaque lines that represent the cortical wall of the canal. So these are the radiopaque band on either side of the canal. And it appears below and sometimes superimposed on the mandibular molar teeth. So here it is superimposed with the apical third of the mandibular second molar. Next about inferior border of the mandible. So inferior border of the mandible is a dense radiopaque band of the bone. You will see in the inferior aspect of the mandible. Next about the coronoid process of the mandible. This is a radiopaque triangular area which is superimposed over or inferior to the maxillary tuberosity region. So this coronoid process will be visible in a maxillary molar projection radiograph. So it is seen on the maxillary molar periapical radiograph. It is not on the mandibular periapical radiograph. That you have to remember here. Next is submandibular fossa. It is a radiolucent area in the molar region below the mandibular molars. So few bony trabeculae are seen in this area. You could see minute small trabeculae in this region. Next is restorative material. So we can see radiopacities over here in the coronal portion as well as in the radicular portions. This thick radiopaque areas are nothing but the restorative materials. So we are here with the conclusion of this topic. So understanding normal radiographic anatomy is essential for accurate interpretation of dental images. So it will enable the clinician to discuss between the healthy structure and the pathological changes, ensuring precise diagnosis and effective treatment planning. So mastery of this knowledge enhances the patient care and contributes to successful dental outcome. And thank you for patient listening.